So the next commonest, on the what's called on the cold orthopedic side, bone tumors are the difficult one. They will be remembered today only to forget today's night, but they are the most important for the necessary evil for the examinations. The other things like fractures, etc. These almost the fractures also will be having the same type of quality. Common factors will be there. Everything will be having the same treatment. So try to catch this, what is called the specific points in that in every topic. Now, supracondylar fracture. It is a fracture in the metaphyseal zone. It is a fracture in the metaphyseal zone. That is the one which most of the people will be doing. Because supracondylar fracture is a fracture, supracondylar fracture of humerus, I am repeating. If you say simply supracondylar fracture, it may be humerus or femur. Supracondylar fracture of the humerus is mostly in the children. Why? Because if you see what is called, if you see the bone, humerus, this is the upper epiphyseal, this is the lower epiphyseal. In case of child, the capitulum, the trochlea, and the main bone all are in the different ossification centers. So this is cartilaginous, this is cartilaginous, this is cartilaginous. And moreover, if you observe the quality of the bone, it is cylindrical stuff, stout stuff and up to here. And once it comes to the supracondylar area, it becomes flattened and thinner. Flattened and thinner. So it is substance have been lessened. Substance have been lessened. And moreover, there are three different foci. That is coronoid foci, radial foci and olecranon foci. So somebody has eaten away even this one. Even this flattened area has become much more weakened by somebody has been drilled away and eaten away these three foci. So this being cartilaginous area eaten away by the coronoid foci, flattened, is vulnerable in children in fracture. That is why this is the stronger area, this is the weaker area. So it tried to break at the junction area. It tried to break at the junction area. So once you fall on outstretched hand like this, so entire forces breaks here because it is a junction point of a weaker flattened area. Not only flattened but also coronoid radial fossa much more weaker. From the stronger area, these forces will try to break away at this metaphyseal area. That is the common fracture which occurs in children. That is how it is occurring there commonly. So it is the metaphyseal, see the coronoid and olecranon fossa, etc. So this is now. The one very important point about this one is the brachial artery is very near to this. Once it is broken, there is no further knife is necessary. Your broken bone itself is the knife. So which is the brachial artery which is going very near it, and its friend median nerve also very side by side almost. Median nerve and brachial artery are almost side by side. In fact, both the ends of the median nerve are adjoining together on the axillary artery. So this median nerve and brachial artery are vulnerable at this area. Mostly the artery is more at the vulnerable area. And then once it fractures, the blood is more, because it is the metaphyseal area, the extraversion of blood and more. And if you observe, around the elbow, around this area, it is much more loose, and then the extraversion of this blood will become much more huge swelling. Need not be brachial artery, need not, even without damaging brachial artery, I am not telling about the brachial artery damage. Only simple fracture will produce more and more blood. So more and more blood will be traversing in the what you call tissue is called ecchymosis. Punctate, hemorrhage and ecchymosis. So you can see the discoloration of the skin like this, discoloration of skin like this, and a huge swelling, So the swelling will be there both at the elbow as well as at the forearm. So suppose if there is a balloon, you blow a balloon like this one and try to bend the balloon. So there will be a kink at the balloon area. Now if you think this is the balloon, if you try to bend a blown out balloon, how much tremendous pressure will be there here. If a balloon is there, if you try to bend this balloon, a tremendous pressure will be occurring at this. In a supracondylar fracture, imagine a balloon The swelling is like a balloon. When you try to flex this one, a tremendous pressure will be there, and that area will be the vascular area. If you bend more and more, it is causing more and more pressure at the brachial artery. So when you want to keep the limb in flexion for your immobilization, the more you keep it, the more the compression of the brachial artery, because it is ballooned out. So you have to come to a certain compromised state. If you don't keep in the flexion, the bone fragments are not locked. When treating the fracture, the bone fragments should be locked, should not move. So when in extension, they will try to move this way and this way. But when you keep in flexion, if there is a fragment here and a fragment here, if you keep it in extension, this fragment may try to move independently. But once you flex it more and more, the triceps muscle will try to act as a splint, and they will try to keep the what is called stability of the limb. If you flex it more and more, the fragments are kept nicely. So for stabilization of the fracture, more and more flexion is needed. But if you give more and more flexion, brachial artery will vessel. So while treating a fracture, can you help me? So when you are treating a fracture, a supracondylar fracture, after reduction, then there is a huge swelling here, another huge swelling here. With this huge swelling, you want to become a flexion. So see how it is happening. This swelling is coinciding here, and then once it goes like this one, as it goes to flexion, brachial artery is compressed. Then you feel the pulses. While flexing, you feel the pulse. Once the pulse stops, then go back to the original position again. So you have to immobilize in a reasonably good flexion position, but not to the extent of causing the pulse. So that is the important point in treating the supracondylar fracture. Because of the swelling, because of the flexion is needed, because it is needed, flexion is more and more flexion, more and more tightness of the, more and more flexion, more and more tightness of the what is called the triceps muscle. If less and less what is called a flexion, the extension, it will be more easy. So you want a splint, but you don't want the artery to obliterate. You have to keep in these 2 points while treating the supracondylar fracture. The rest of the fracture treatment is almost unique with the other things. This is the point you have to remember. Now this is the one. So first in this what called most serious fracture of childhood associated with the dangerous complication of vascular injury, fracture through the supracondylar zone. Supracondylar means there are 2 pillars. This is one condyle, this is another condyle. One is capitulum and the second is trochlea above the condylar levels. And then fallen outstretched hand is treatment. Large swelling, bruise is there, that means ecchymosis. Obvious deformity will be there. And then often obliteration of the distal pulse. Because of the swelling, there may be obliteration of the distal pulse. These are the important clinical points in the salient points. There are 3 types of treatment. You can reduce it closely. You can reduce it closely without opening, that is normal closure reduction, plus post plaster of Paris application. But remember, when you reduce it closely on applying plaster of Paris, you should remember that you should apply only a slab, not a cast. Slab means only on one side, like your cricket person's batsman. If you put a cast, it will become more and more tight and vascular impediment there. Vascular impediment will be there. So you have to give the post class. So you have to keep it as much flexion as possible, but you should not obliterate the pulse. So if it is possible to keep the inflection without causing the obliteration, you can give it like that one. But when you are not able to keep the flexion sufficiently, suppose if you are getting pulse of obliteration at this level only, if once you flex it like this, it is causing vascular problem. Then the second method, closure reduction plus K-wire application. So you need not keep the limb in absolute flexion. You can keep in 90 degrees also, but under seeing this arm, you fix the fragments and with the K-wire, then you need not have a flexion. You don't have a triceps splint need not necessary. And then If there is large swelling, the two treatments are not being done nowadays, they are not so popularly, but for entrance they are giving even sometimes older treatments also. So tractions, you can have tractions when you use swellings. One traction is a skin traction, that means you apply the skin traction over the arm like this one, that is a Dunlop traction, that is skin traction. And another traction is called pin traction, that is K-wire application, and that is through the olecranon. You can see the olecranon, this is the olecranon, this is the pin going to the olecranon, and that is the Bohler stirrup used. This is the pin going to the olecranon. So this is called Smith's traction. This is Dunlop traction, that is Smith traction. Since Smith traction is the traction applied by the K-wire through the olecranon for supracondylar fractures. So this is the salient point of treatment. The salient points on complications are taken by vascular complications like what is called obstructing the vessels. The result of a vascular complication depends on the collateral circulation. If the collateral circulations are very good, there may not be any effect at all. If the collateral circulations are good for a resting condition, but not when the muscles are actively working, are you able to understand me? If the collateral circulations are good for the normal function, but not for exercise condition, then the patient will suffer from exercise ischemia. So the patient will not having any pain, but when he works severely, he will get pain. That is what is almost thromboangiolytic obliterans type. The third condition, if the collateral circulations are not sufficient even for exercise condition, not sufficient for rest, not sufficient for exercise, and then, but it is supplying as a nourishment, a little bit nourishment, not to have a complete deleterious effect, then the patient will result into exercise ischemia, when the muscles go into ischemia, and all the muscles, nerves will go into contractures, into fibrous tissue. So when the circulation is not at all sufficient even to maintain the anatomical structure, then it will go into gangrene. If the collaterals are good, there may not be effect. If the collaterals are just sufficient for the resting condition, exercise ischemia. If they are not sufficient for even for resting conditions, but to maintain the architecture that is sufficient, then it will go into exercise ischemia, that is Workman's ischemia in this case. And in the case of what is called other conditions, wherever it is there, ischemic contractures. And then the final thing, if they are not sufficient at all, then it will go to what is called, then they will go to, yes, gangrene. Then you have to remove the limb. So all these four complications may be there depending on phase. So it may involve all the three nerves, but the commonest nerve is median nerve because anatomically near. And it is myositis ossificans. Another complication is myositis ossificans. What is myositis ossificans? If you want to say, ironically, it is iomyositis ossificans. It is a confusion. Myositis ossificans is nothing but a confusion of the body. So what happens, I will tell what is the confusion of the body. Now suppose there is a fracture. This is bone. So this is medulla. So there is a fracture. So there is a blood here. So once there is a fracture, there will be stimulus, will go to the higher center, neuronal center, and say there is a fracture. Then comes all the armamentorium, every phagocytes and municipality workers, every phagocytes, everything, osteoclasts will come and try to convert into the bone in due course of time. They will remove away and try to convert into the bone. Their primary ultimate aim is to convert there into a bone, convert bone formation there and make the fractures. So this is at a fracture site. So at a fracture site, when the blood is, hematoma is collected, this hematoma sends stimulus and try to come, and the body's mechanism comes and try to make it a bone. But Even at non-fracture site also, when there is no necessity of what is called a necessity of bone, a hematoma stimulated for bone formation is myositis ossificans. A hematoma is there because of the injury, because there need not be any bone, there is no need not be any fracture. At that level, there may be a fracture and hematoma, but at that collected hematoma, there is no need of bone formation. But the fracture, the hematoma, which is normal hematoma, is being confusedly treated like a fracture hematoma. This hematoma erroneously, confusedly is treated like a fracture hematoma. That is myositis ossificans. That is why in Telugu I call it as myositis ossificans, because it is in confusion. Ayomayam ante they were Telugu only people know. So myositis ossificans. So it is a confused body to convert a normal non-fractural heady hematoma into a bone. So this is there is a lot of blood collected here, and it not only the fracture hematoma but also muscle hematoma, everything is converted there. The fracture hematoma should be there between the bony fragments, but the hematoma which is not there in between the bony fragments, which is there under the brachialis muscle, also being converted as a bone. So usually myositis ossificans will occur under the large sized muscles. Brachialis is a larger area muscle, quadriceps is a larger area muscle, gluteus is a larger area muscle. Under the muscles which is having a larger area of distribution, these things will occur. It is cubitus varus. Cubitus varus also occurs in supracondylar fracture. Cubitus varus means medial deviation. So these are the important points. Now, a fracture just proximal to the bony masses of trochlea and capitulum. Fracture line often it runs transversely through the apexes of the coronoid as well as olecranon fossa. This is the olecranon fossa apex and this is the coronoid fossa apex. Olecranon and coronoid fossa apex. Through these apex it will pass. Fracture line goes through the apex of the coronoid as well as olecranon fossae. There are two types. If the fragment is, there are two types, extension type and flexion type. Extension type is the commonest type. Most of the time you will see that type only. Flexion type is very, very rare. In the extension type, the fragment will go backwards. What is extension for this limb? It should go back. It should go back. So the limb, what is extension in the upper limb? Almost going backward. At this elbow, going backward. So the fragment goes backwards. If the fragment goes backwards in relation to the proximal fragment, that is extension type. In order to not to have a confusion, what is extension, what is flexion type? Remember, what is extension? The forearm is going backward, so the fragment goes backward. In a flexion type, the fragment is forward, that is tilted come to the forward, that is flexion type. So that is coming anteriorly. So that is a tilt. There are a lot of differences here because the supracondylar fracture involves so many disorders. I will show what are the various different. Now I am in this square area. Here there is a square area. I am in this square area, and if I am come to this, beyond this shift area, beyond my original axis is here, and I came the entire axis parallel to them, this is called shift. This is called shift. So you can have an anterior shift or a posterior shift or a medial shift or a lateral shift or a proximal shift. So if my axis is there itself in the original position without moving it, if the other body the axis root is still there, but the axis is coming anteriorly or tilted without moving it, angulating like this one, this is called tilt. This is called tilt. This is anterior tilt, this is posterior tilt, this is medial tilt, this is lateral tilt. And then rotation, you know, this is rotation, this is rotation. The supracondylar fracture will be having supracondylar fractures will be having all these things. There may be a shift and tilt. There may be a shift and tilt. There may be fracture migration. There may be rotation. All these points will be there in the, that's why you should know what is tilt. Now see, See, if you see, though it come forward, moreover tilted forward also. It gone backward and tilted backward also. So, this is the what is called tilt and this one. So, this Gatland type of classification, this is unusually, but if you draw a line like this one, the capitulum will be, most of the, about 2/3 about will be in front of this one. If you draw a line, like this one, this is capitulum. If you draw an axial line like this one, the capitulum, if you draw a line like this one, capitulum will be anterior to it. Anterior to it. That is normal. Capitulum sits in relation to the line, anterior to it. Now see this one. The Garland type 1, this is not what is called type 1. There is a fracture, but there is no much shift of the capitulum. And then there is no much shift. A little bit shift is there. And then type 2, this has gone backwards. That means there is a coronal injury, coronal plane. There is an injury in the medial and lateral plane and rotation also. It has not gone back, but it appears as if it is opened mouth. That means there is a rotation. If it is not changed, and if only a simple transverse fracture without displacement, this will not be there. That means there is some coronal tilt or rotation. So that is the granted with the coronal plane deformity. There is a coronal plane deformity. And the type 3 is almost detached, gone way. These are the 3 types. Now clinical signs. These are the 3 types. One is undisplaced. The second is displaced, but it is open, but is not gone backward. It is only, there is a continuity, but coronal region tilt is there. But the third type almost gone in the winds. Now, there is a posterior prominence here. There is a posterior prominence here. Now, for this, now if you see the 3 condyle, this is epicondyle, this is medial epicondyle, lateral epicondyle, olecranon. If you extend the elbow, all the 3 are in the same line. All the 3 are in the same line. But once you flex it, the olecranon goes front and forms a triangle. Okay. That is the important landmark. This forms a triangle. How about this triangle you should know now and then. Now, because there is no, I am not having elbow, itla better. Now, if you think itla better. Now, if you think this is the ulna, if you think this is the ulna, it is like this. If you think ulna, this is like this. This is olecranon. This is olecranon. This is olecranon. This is olecranon. This is medial epicondyle. This is lateral epicondyle. Suppose if there is a posterior dislocation, like this, it has been covered. Cloth, chinna cloth. Now this you think as the this is olecranon. It like this. This is the elbow joint. This is the normal elbow joint. Normal prominence of olecranon. Suppose if there is a dislocation, now it has gone like this one. If there is a posterior dislocation, that means the olecranon is very, very prominent here. Even if it is a supracondylar fracture also, because the lower fragment has gone with that one, then also the same swelling occurs. If you think it is the supracondylar, if this is the supracondylar area, this black is this is the supracondylar area, this one. If there is a dislocation, it will be like this. If there is a supracondylar fracture also, it will be like this. It has gone like this. Even the supracondylar fracture, the fragment and this has gone like this. If it is a posterior dislocation, it has gone like this. If it is supracondylar fracture, it is like this. So from the covered area, when there is a coverage of skin, you don't know whether it is a supracondylar fracture or posterior dislocation. So there are differences. So that is the point of alakna. Sorry. So that is the point which we want to elicit upon. If there is a posterior dislocation, the alaknon goes there somewhere. So the relation between the 3 points have been changed. Whereas in the case of supracondylar fracture, this point and the one, both are all in the same fragment. So there may not be any change. Supracondylar fracture means both condyles have gone with the alaknon. So the point, the triangle is still there. Whereas in the case of posterior dislocation, this has gone away and that 3-point relation is not there. Okay? When a supracondylar fracture, the arm becomes shorter because of the fracture of the humerus. Arm becomes shorter. The forearm becomes lengthier. Arm becomes shorter. Whereas in posterior dislocation, arm is normal, but there is what is called lengthening of the forearm. Like that. We will share the tape. But we are not worried about this one. The 3-point formula is very, very important. So, now understand, since the fracture is above the condyles, the 3 bony points relationship is maintained as in normal elbow. Unusual prominence of the point of the elbow because the backward tilt of the fragment, not only twist but also tilted. So, not only fragment shifted but also tilted. So, all will make an apparent view of the posterior dislocation because they are not seeing through the naked eye. So, the 3-point relation is very, very important, which is there in the case of this one, which is not there in the case of the posterior dislocation. 7:15. Now see this one, this swollen like an elbow, balloon like this, and this I told you. When you try to flex it more and more, the pressure will be more and more, and exactly the pressure will be at that area of the brachial artery. And the brachial artery and median nerve are going together like this one. Clinical signs, there is a possibility of blood supply interruption of the blood supply to the distal extremity because of the associated brachial artery injury. And there must be carefully looked for, okay. Radial and ulnar pulses may absent with or without the signs of ischemia. I told you already, radial and ulnar pulses may be absent, but the microcirculation may be maintained. Microcirculation may be maintained through some other route. So, ischemia may not be present at the first beginning itself. Ischemia may be a symptom afterwards. One, that is how the brachial artery is going to be injured, kinking. There may be transient kink. Yet the collaterals may be mating. The kink may be recoratron, may be supply, okay. One must look for an injury in the median nerve. Median nerve injury is due by pointing index finger. Why pointing index finger? Because this part of the fingers, 1.5 fingers, this part of 1.5 fingers can be flexed by the ulnar nerve. And this part is supplied by the median nerve. So when you want to make a clasp like this one, this index finger will not flex, so it will point out like this. It will point out like this. So when a median nerve injury occurs, this will flex completely, this may flex to some extent. This, because of the influence of some slips, it may try to flex a little bit also, but this will never flex because it will be completely supplied by median nerve. Though it also won't flex, but to some extent it will be like this. So there will be a serial flexion. It is called serial flexion. That is called Benedictine attitude. This is also called as Benedictine attitude. Serial flexion. So keep the finger in the Benedictine attitude and try to what is called make a fist. It is pointing index finger. A pointing index finger and a pointing index finger in a pointing index finger. That is clasp knife, the Ashner's clasp knife. If you clasp fingers, if you remove it, it is now there is the serial flexion. Both are almost same. Serial flexion is called Benedictine attitude because Benedict means not Benedictist. Benedict means preach, my lords. I request all the persons to serve the human beings. Church priest will be keeping like this. This is called Benedictine attitude. So median in pointing index finger, and if it is a nerve injury, that is wrist drop. Now this is the displacement. This I have already told you now. See this one in an AP view. In an AP view, there will be a proximal shift. There will be a medial or lateral shift. There may be medial or rotation. Medial or lateral rotation. So that is all the shift, lateral shift. This is medial shift and the rotation. You can see medial. You can see medial or lateral shift, proximal shift. You can see. In the lateral view, you can see the posterior shift, posterior tilt, posterior shift, as well as rotation. As well as rotation. So these are the things you can see. So shift, tilt, rotation, you know now.